Good afternoon, everybody. Thank you for joining us today for the Science Innovation Theater. Today we're going to be discussing cutting-edge strategies against CMV, breakthroughs in hyperimmune therapy. This session is sponsored by Kamada, and at Kamada we believe each life is unique. My name is Winston Alley. I'm the Director for U.S. Medical Affairs at Kamada. So I'll be providing you all a brief introduction to our company and our clinical program, and then I'll be turning it over to our main speaker, Dr. Lorenzo Zafiri from Cedars-Sinai. Kamada has been around for 30 years. We're a vertically integrated global biopharmaceutical company with a focus in plasma-derived therapeutics. We have a distribution network in over 30 countries, and we have 8 specialty products that we market globally. We have 6 products that are FDA approved, and a large part of our portfolio is focused on transplantation. We have the broadest hyperimmune portfolio in the U.S. market, and so that really is our focus and why we are seeking to meet the unmet needs in patients such as transplant. But what is a hyperimmune therapy? It's something we talk about a lot, but what is it really? So hyperimmune globulins are formulations prepared from plasma pools from large number of donors with elevated titers of antibodies to specific infectious agents or to other antigens. The function of this is to give passive immunity by neutralizing circulating virus particles and facilitating their elimination. Our product portfolio is Cytogam, Hepagam, and Verizig gives us 3 products that are aimed as hyperimmune therapies to help transplant patients. I'm a transplant pharmacist by background, and it's very interesting to me to understand how hyperimmunes are actually made. And just like transplantation, it all starts with the donor. It starts with screening, and so for products such as Cytogam, we actually have to screen donated plasma to see if the patients have a high antibody titer to CMV. As compared to our rabies hyperimmune globulin that we manufacture, we actually focus on finding donors who have been recently vaccinated with rabies. So these are 2 different strategies that we use to identify the appropriate plasma. Then, of course, we undergo plasmapheresis, and we use that plasma to then further process into the final product. As it relates to Cytogam, the manufacturing process starts with about 10% of the plasma that's collected that's identified as having a high enough anti-CMV donor. Then we undergo purification steps and fractionation steps to pull out the immunoglobulins, the IgGs. And in so doing, we actually concentrate the amount of anti-CMV antibodies. And so the final product that's released for patient care actually has a concentrated amount of anti-CMV, even compared to the high donor antibody titers in the general population. Kamada recently acquired this portfolio of products, and in part in doing that, we also instituted a clinical program. And so our clinical program is really aimed at creating new published data in solid organ transplant space as it relates to Cytogam. So we're focused on engaging centers to communicate existing data of ongoing use and get that published so that clinicians have this available to help them make patient care decisions. We're looking at generating new data through prospective studies to enhance our understanding of hyperimmune globulin therapies. And we're also engaging clinicians in studies to look at novel approaches to really change the way that CMV management is done, to really identify an individualized or personalized approach for managing patient CMV. Dr. Lorenzo Zafiri, he's the Associate Medical Director of Lung Transplant at Cedars-Sinai, and he'll be covering anti-CMV strategies and immune response in lung transplantation.
Hi, thank you, Winston. Thank you, organizer, and thank you, Kamada, for the opportunity to be here. These are my disclosure for today. And the objective of my talk are first to review the recent data presented by Dr. Torres, who also gently provided those data for presenting today, and to share his experience with a combined multimodal approach to CMV prophylaxis. And then we'll try to look at the evidence that can sustain the use of a multimodal approach for high-risk CMV mismatch lung transplant recipients. You know that CMV mismatch is associated with a poorer outcome in lung transplant recipients. There is evidence from single centers, and later we'll also review data from a larger retrospective data. And for this reason, the group in Dallas, led by Dr. Torres, decided to adopt a multimodal regimen for anti-CMV prophylaxis for the CMV mismatch, so high-risk recipients. And this regimen includes an antiviral and a CMV hyperimmune immunoglobulin with the dose and the schedule that you can see in this line. They presented at ID Week last year their retrospective analysis that included over 300 lung transplant recipients. You can see on the side the classic clinical characteristics that kind of portray for most of our lung transplant centers, age between 50 and 70s, mostly Caucasian with restrictive lung diseases. And then divided the group in two groups, the patients into groups. The high risk, they represent about 26% of the patients versus everybody else that had different CMV matching. Busy table. The first is the clinical characteristic at the time of transplantation, and between the two groups, there weren't many differences. The only significant difference was the fact that patients were on ECMO or require pressors, mostly in the high-risk groups. And then in the 3-year survival, the only difference was the days in the number of hospitalization after transplant. But interestingly, what they saw is that there was no difference in the survival at 1 and 3 years for the CMV high risk after the use of this combined multimodal approach. Also in their multivariable analysis adjusting for different characteristics, CMV status disappear as a cause of poor survival. So why is this happening? We're going to try to look a little bit more in the next few minutes. Why is there is the impact of CMV and what we can do with this multimodal approach to help our patient to survive longer. As you know, CMV is a classic herpes virus that is characterized by a broad tropism, tissue tropism, and the ability to establish latency. If you look at the CMV Facebook profile, he has a complicated relationship with the immune system, and it's very, and it changes with time, and we're learning more about it. If you look at primary CMV infection, you will see in immunocompetent patients, most of the time is a silent infection. We don't even understand when, usually in the childhood happens. But in immunocompromised, there is a variety of syndromes that can happen depending on, starting from the CMV, the anemia, viremia, and ending with end organ diseases. In the middle of all of this, we know that there is the immune system that starts to respond. There is a strong response from natural killer cells, and we actually know that there are specific subset of natural killer cells that they increase in frequency in the setting of viremia. There is production neutralizing antibodies and therefore activation of B cells. And finally, obviously, there are adaptive cellular responses with CD8 in particular that are very important in controlling the viral replication and then establishing that complicated relationship during latency. And as mentioned earlier, the CMV donor status is very important. Receiving an allograft that is CMV donor positive, it is associated with worse outcome. This has been shown by this retrospective analysis of over 10,000 lung transplant patients between 2005 and 2015, looking at the SRTR data registry. And the worst survival, unfortunately, was, as you can imagine, from the donor that were positive and recipient negative, so a CMV mismatch. Why is this happening? What is the detrimental impact that CMV can have? On top of the infection and therefore the direct cytopathic effect of the virus on different organs, pneumonitis, gastritis, and so forth, we have been learning that there are indirect effects of CMV infection. There is an increased risk of opportunistic infection. That's through immunoevasive mechanism that CMV established that cause an immunomodulation of the immune system, and therefore an increased risk of bacterial and other opportunistic infection. There is data suggesting that there is a change in the dynamic, the shape, and the functionality of effector T cells, and we're learning more that there are specific subsets that are associated with clearing the viremia and less clot versus other patients that are not able to develop this effector T memory. And finally, there is this association with rejection. That has been well studied in heart transplant, where CMV viremia is associated with vasculopathy and heart rejection. There is contrasting data in the lung transplant field with some centers that have shown that there is an association with CLAD, and a more large study that have found higher mortality, but not related to CLAD. So what can we do, and what do we know about the use of hyperimmune immunoglobulin against CMV? There was one randomized clinical trial with single therapy, monotherapy with CMV IG that didn't help. It was not able to reduce infection, wasn't able to reduce acute red cellular rejection. However, along with the data presented from Torres, there is data from Valentine, from Zamora, that showed that in a combined multimodal approach using antiviral and CMV hyperimmune IG, we can see less bacterial infection, less acute rejection, and less BOS, at the time it was called BOS, or CLAD for lung transplant recipients. How that is work, what's happening, what is the mechanism? So we can look at immunoglobulin infusion, and we can see that there is an immunomodulatory effect. In fact, the infusion of IVIG is associated with reduction of the B cell activation. That because can interact with the B cell receptor and other surface marker. We can also block and neutralize autoantibodies and other cytokine and the B cell activation factor. And there is enough evidence showing that also the infusion of IVIG can help increasing the frequency of the regulatory T cells through the stimulation of dendritic T cells. And we've been hearing all day that the importance of regulatory T cells in helping with autoimmunity. So these are important data that comes from IVIG. What do we know about specific CMV hyperimmune immunoglobulin? There are two studies that I want to go through briefly, both from Europe. This is from the group in Vienna, and they've been using a multimodal approach with CMV IG along with antiviral for several years in thoracic transplantation. And their goal in these in vitro studies was to try to understand the immunomodulatory effect of giving CMV hyperimmunoglobulin. So they established two different models of T cell activation. The first one is called the mixed lymphocytic reaction, and the second is the stimulation of the lymphocyte with anti-CD3. They obtain PBNCs cells from healthy donors. They culture in presence of irradiated PBNCs or anti-CD3, and in presence of increasing doses of CMV-IG. And they saw in a significant reduction of the proliferation, and that was dose-dependent. They also, in the supernatants of the cultures, they measured the interferon gamma in IL-2 and IL-10, and again, they saw a significant reduction of the production of these inflammatory cytokines. They also asked, on top of that, do we actually have also a functionality response? And so they culture PBNCs and purified NK cells from healthy donors and culture in the presence of CMV-IG and with two different cancer cell lines. And again, in a dose-dependent manner, they saw that there was a reduction in the cytotoxicity, so the reduction on the activity of these cells, again, stimulating this idea of immunomodulation. And this is the second study, similar idea, different approach. This is from Netherlands. They wanted to test three different products. The first is an older CMV-IG manufacture style. The second is the more modern CMV-IgG. And then also they use in the fourth column, they use hepatitis IG immunoglobulin. And they saw that when they use human PBNCs and splenocytes, again, after stimulation of PHA, which is a strong stimulator of proliferation and activation of T cells, they saw reduced proliferation and reduced production interferon gamma in both cell lines. So this study suggests that there is in vitro enough evidence to say that there is something happens to the T cells that they seem to be less active. I want to go through a couple of cases and try to stimulate a little bit your brain and try to see if you could think that there might be a possibility to use CMV-IG. We have a 65-year-old female with a bilateral lung transplant for rheumatoid arthritis, ILD, CMV mismatch. Received immunosuppression with basiliximab at induction, then a triple therapy, and she was on antiviral medication only for 11 months. Due to classic side effects, leukopenia, GI problem, she started to peel off some of this medication, and she wasn't able to tolerate either mycophenolate or valsite. And as many centers, we have been going back and forth, we're using one or the other. So at that point, we already started to ask, would it be here a possibility to introduce a second agent to help with the control of the viremia? In August, she developed CMV viremia because she was off antiviral therapy, and valganciclovir was restarted. September, she developed acute rejection with elevation of the cell-free DNA, received steroids, so augmentation of immunosuppression. In November, she had persistent elevation of her cell-free DNA and decline in the lung function, and therefore we decided to escalate therapy and decided to give her anti-thymoglobulin. At this point, we have CMV reactivation and recurrent rejection. In my opinion, this is a possibility to use CMV-IG to implement not only the control of the CMV viremia and the CMV reactivation, but also helping with this immunomodulation effect to prevent further rejection. Second case, a 66-year-old male with a left single transplant for interstitial lung disease. Again, CMV mismatch, similar immunosuppression strategy with basiliximab and then triple therapy. Went very well for the first year. 11 months, in our center, we completed the prophylaxis. However, at the one-year surveillance bronchoscopy, found to have acute cellular rejection, but with decline of lung function, symptoms of dyspnea and shortness of breath. We decided to give him steroids as for protocol, and a month later came back with more hypoxia, more shortness of breath, and was found to have CMV dynemia. Lung biopsy was performed again, and they found evidence of CMV pneumonitis. So that, again, to me is a good case to start thinking, maybe we should change our approach to this patient and try to see if CMV-IG could help in bringing down the inflammatory response. We saw valganciclovir as per protocol, and we had a very good response in terms of logarithmic decline in the CMV dynemia. We went from over 150,000 to less than 1,000 in about a month. However, we never reached negative levels. It's always been a very low threshold on the PCR, was always a little bit positive. And continued to have problem and developing shortness of breath and declining lung function. Again, this is probably another patient where the use of multimodal approach to treat the CMV anemia, to control the virus and reduce the inflammation, and maybe having an immunomodulatory effect on the lungs might be helpful. So in conclusion, the use of CMV Hyperimmune IG is associated in single-center retrospective study in survival benefits in CMV mismatched lung transplant patients. The effect might be associated with a better control of CMV replication. However, where there is evidence in vitro that there is an immunomodulatory effect. I think the future is, as Winston was suggesting, a multi-center prospective study that should consider further evaluate this possibility and study a little bit more how CMV can be controlled. Thank you.
Thank you, everybody, for joining. We'll be taking questions over here in the front if you have any. I really appreciate your time.